What is a healthy person? How do you actually define a healthy person? Because a lot of people do it by appearance. But I know a lot of people that have a six-pack, lots of muscles, and I wouldn't call them healthy.
Let's be very clear that we don't have a universal definition of health. There's just too much going on underneath the surface that is much more important than what someone looks like. And the phrase I use a lot is bigness is not the same as badness.
When it comes to GLP-1s, very popular, a lot of people are talking about it. How do they work? What are the risks of taking it when you actually don't need it?
Let's face it, the popularity of these is driven in great part by their perceived cosmetic benefit. They make people smaller in a world where a lot of women are pressured to be smaller. Rather than adding another layer of blame, we put extraordinary amounts of pressure on people, particularly young women, to look a certain way. This, again, it's a symptom of a bigger societal issue around what we say about people's bodies.
So if someone is listening to this and they're like, I can't control what family I was born into, my genes, what would you say to those people that are like, everyone in my family is overweight, so it must just be genetic and I can't do anything about it?
There are things that we can do without medications and without surgery. The first thing is,
it is so frustrating. I feel like I'm training so hard. I'm working out. I am looking after myself, but the weight is not shifting.
I just don't know what the to do anymore.
Is it my hormones? Should I be avoiding HIIT exercise?
No matter how much I try, I can't stop eating chocolate.
For so many women, weight becomes a battle, a number, a judgment, a story we never chose but somehow inherited. But what if weight isn't the problem? What if it's a message, a signal from a body trying to communicate? Not the noise we're constantly fed. Keto, fasting, Ozempic, hormones, cortisol, genetics, shame, but real information without blame, without fear. That is the question that led us to create our Weight and Metabolism series, exploring weight through an unbiased approach combining medical, functional, and energetic understanding. We sit down with leading experts and real women to reframe how we understand weight, health, and the bodies we live in, giving you clarity, context, and a way forward. This is What's My Body Telling Me, the podcast where we let the body do the talking and we listen differently. In today's episode, we're covering one of the most talked about and misunderstood parts of the weight conversation, the medical side of metabolism. This episode helps you understand and make sense of so many questions that we're asking ourselves right now, like, why won't my weight shift? Is this my hormones? What about my metabolism? Is Ozempic actually for me? And if I take it, am I cheating? To unpack all of this, we're joined by Dr Alex Craven, a leading bariatric and metabolic surgeon who specialises in obesity, metabolic disease, and long-term health outcomes. He's incredibly down-to-earth, compassionate, and has a beautiful way of explaining complex biology in a way that finally feels clear. His work spans lifestyle interventions, obesity medications, and surgery, giving us a full evidence-based view of what's happening beneath the surface. So if you've ever wondered what you can do on a medical standpoint for your weight and metabolism, today's episode is for you. Dr. Alex, as a general surgeon who specialises in providing weight loss surgery and support for metabolic disease, what is metabolic disease and how would someone know that their body is showing signs of it?
Yeah, it's a good question. And I think what I would suggest is what we're growing to understand is that metabolic disease isn't so much a disease, but rather a whole field of medicine. And so I guess to make it clear, we're going to talk about a lot of things. I'm going to use the word obesity a lot. And it's probably worth us making clear that when I say obesity, I'm talking about a collection of processes going on in the body. I'm not really talking about things that we can see, shapes and sizes of people's bodies and that sort of thing. What we're really talking about is there's a group of hormonal, cellular, chemical processes going on in the body that can cause us harm in a variety of ways. One of those ways is we can lay down fat tissue. Also, where that fat tissue is and where it's laid down can vary. So from places where it's less harmful to places where it's more harmful. These processes can also be pro-inflammatory, so they can cause or contribute to a range of inflammatory conditions. These processes can affect the way our bodies handle its energy sources. So the way sugar is handled and things like diabetes, the way cholesterol and fats are handled by the body. These processes can harden arteries and cause damage and risk of things like heart attacks and strokes and kidney disease and pretty much disease in any organ in the body. And they can even be pro-malignant. That is, they can directly lead to precancerous and cancerous changes in the body. So when we talk about this group of processes, there's an enormous amount of variety. So what metabolic disease is really depends on the person. And it may, and it's not all happening to the same degree. So some people can lay down a lot of adipose tissue, a lot of fat tissue, and really have none of the other things that I've spoken about. Other people can lay down very little adipose tissue, but have a lot of those other issues from metabolic disease, type 2 diabetes, metabolic liver disease, heart attacks, strokes, all those sorts of things. So really, I think metabolic disease now is for obesity treatment, whatever we want to call it. And you'll see all sorts of phrases that are kind of pointing to the same thing: cardiometabolic disease, cardio-kidney metabolic disease, or metabolic heart disease, and all those sorts of things. What they're really pointing to is this idea of what I refer to as obesity, which is this collection of biological processes causing us harm.
So someone could have more adipose tissue, so they look like they have more weight on them, and not have metabolic disease, and someone could have not as much weight on them and have metabolic disease. Is that what you're saying?
Absolutely. And the phrase I use a lot is bigness is not the same as badness. So it's worth being clear that on average, on the population level, if we look at hundreds of thousands of people in big population-based studies, in general, as weight and BMI rises in that population, we see more of these metabolic diseases. But at the individual level, that relationship breaks down. So the amount we weigh is a combination of fat tissue and other types of tissues. So weight in itself is sort of not a great marker of adipose tissue, which is what we're really talking about when we're talking about increased weight. We're not talking about weight loss or weight gain. We're talking about fat gain or fat loss. Mm-hmm. Second, it's not so much important how much of it's there as where it is more important. So a lot of women, for instance, will carry adipose tissue, breasts, thighs, under the skin. And that on average tends to be a lot less harmful than fatty tissue in the abdomen or in the chest around the organs. In turn, that's less important than when we see fat in the tissues where it doesn't belong, what we call ectopic fat. So people can actually have fat cells within their liver, within in and around the heart, in places where we're not really expecting to see fat cells. And then at the end of all of that, it still depends really much more on what impact that fat tissue is having on the body as to whether people live, die, develop disease, etc. And so when we look at weight, we're really many degrees of separation away from really defining people's risk and really defining people's disease load. So that's often misunderstood. And so we have, and it harms us in both ways. On the one hand, we look at people and think that we can make automatic snap judgments about their health, about their risk of dying. And with that comes a lot of stigma and blame and sort of psychological harm potentially. But the flip side's also true, because we look at people and because of their body shape, we automatically assume, oh, this person doesn't have the processes of obesity going on. They don't need our help. And then when we scratch beneath the surface, we're seeing, we're normalizing the presence of diseases like metabolic liver disease, type 2 diabetes, all these sorts of things. But because that person's not carrying a big body, we suddenly think it's okay not to treat those processes and let them go on to those diseases. So it's working against us both ways. We're assuming people with big bodies are unhealthy when sometimes they're not. We're making judgments about their lifestyles and behaviors that just aren't valid. And then on the flip side, a whole lot of people that would be really radically helped by implementing treatments that affect these biological processes that we call obesity are being ignored just because their bodies don't look big enough for us to pay attention.
So it's almost like we need to unhook the link of skinny means healthy and fat means unhealthy, essentially. Like if you're just looking at appearance-wise, we have to look underneath the surface.
100%. Yeah, and it gets complicated because, of course, there's all these sort of social norms around skinniness and health, and then there's the aesthetic ideas and sort of these ridiculous expectations of women in terms of body shape and body size, and all of that sort of pressure gets roped in there as well. And I think a big part of detangling that is really having honest conversations about what health looks like, that people's health is not heavily dependent on their body size, that body size in a very big way is sort of an output of these processes, not a cause of them, and that we can make massive radical improvements in people's health without needing to reduce them to some sort of average body size, sort of fictional normal body size, or what we think is an aesthetically pleasing body shape. That's not necessary to make a really big difference to people's health.
So what would you say is a healthy person? I was thinking about this the other day because I have some friends up here. I live on the Gold Coast, so it's very hot. People generally don't wear as many clothes as they do when I go back into Melbourne. And there's a lot of people that are like really hell-bent on appearance, and particularly men as well, taking testosterone. Women do too. And it got me thinking, what is a healthy person? Like, how do you actually define a healthy person? Because a lot of people do it by appearance. But I know a lot of people that have a 6-pack, an 8-pack, lots of muscles, all the things, and I wouldn't call them healthy. I'd be thinking, your sleep is terrible, you don't have much energy, your hormones are all over the shop. So I'm like, I actually wouldn't think that you're healthy, but from the outside, a lot of people would. So from your perspective, how do you define someone that's healthy?
Yeah, it's a tricky question, isn't it? Because we don't really have it. Let's be very clear that we don't have a universal definition of health. If we did, I promise you it wouldn't be something that we could encapsulate with our eyes. There's just too much going on underneath the surface that is much more important than what someone looks like. I think, from a pure medical point of view, some things to look at is how long is someone going to stay alive and functional on this planet? Now, of course, we can't really measure that until they've already died. So it's a bit retrospective and it's not great, but we can look at risk factors for oncoming disease and early death. So that, from a medical point of view, who's likely to develop disease and end their life early, who's going to live longer? That's probably not a bad thing. And a lot of studies look at survival and those kind of things. But that's just survival. I don't know if that's really health. The next thing, I think, from a purely medical point of view is that accumulation of named, measurable, detectable disease. Things that we know cause harm, and really who's got those and who's doesn't. But again, when we're looking at that, that's the absence of disease. I don't know that that's the full story on health. Then we step one back further and say, okay, well, if we've got people that have an absence of disease and are not likely to die soon of preventable causes, then maybe we should look at things about how, from a physical sense, how's their body functioning? Because I think most of us would feel that the function of the body is probably more important than its cosmetics. Maybe some don't feel that way, but does that body do the things they need to do? Fitness in the term of fit for the task at hand. Does my body let me do the things I need to do to enjoy my life, or is it holding me back from doing those things? And then, just as importantly, is from the mental side of things, where am I sitting in all those things that you mentioned, that sense of fulfillment in your life? Things like, ability to enjoy, to take on challenges and overcome them, all those sorts of things from a mental health perspective all fit in there. So I don't really have a good way to explain that. But I don't think many do, but those are the things, if I was sort of sitting down myself thinking about, am I healthy right now or I'm not? Those are the sort of things I'd go through. Is there anything at risk to my life right now? Am I carrying diseases I could get rid of? Is my body, are there ways my body's functioning that are holding me back from enjoyment and fulfillment in my life? And then are there things going on in my mind that are likewise holding me back from fulfillment and enjoyment in life?
Mm.
And so that's sort of where we often start with conversations around health is it's really a personal, what's your life right now? What's happening with your body and your mind, and where are the gaps? Where are the opportunities for improving that experience for someone?
Yeah, absolutely. I think I love the way you put that. And that's something similar to what I landed on was, I feel for me, if my body is adaptable, that to me is healthy. It's like you think of basic homeostasis. Your body wants to balance. If it can, there's a stressor and it can meet it and then it can come back to balance. That's what I want to be able to do, that functional side of things. I think that's...
Yeah, I was thinking that myself. And for me, a lot of it came back to family. Like, can I lift my kids up above my head? I don't know why that's so important to me, but it's a thing that I've got in my mind that I must always be able to lift my children above my head. I must always be able to carry my family.
Always, even when they're like 30-year-olds and you have to lift them above your head.
I'm going for it. Because there's something about that to me that means something. And if I can do that, that's enough strength. I don't think I need more strength than that in my life. I don't need to chase an endless goal, but I think that if I can maintain the ability to lift my family members above my head, then I'm going to feel like I'm strong enough for the rest of my life. And so I think it can be as personal as that. I think it's okay that it's as personal as that. And then I think that the danger is, though, when you're looking at the personal and the real goals, just making sure that you're also just ticking off those other checklists, diseases that I can make go away, things that might shorten my life. Because I do think in a very real sense, health ultimately comes down to, it's like a chain. Our chain always breaks at our weakest links. And so if I have wonderful cardiovascular health and fitness, but with my pasty white guy skin, I'm going out getting melanomas, that's going to get me. It doesn't matter how strong I am. If melanoma will not care how strong and fit I am. And there's all sorts of, that's just one little example. There's a million examples, but I do think that we want to be careful that we build a strong chain. And we're often tempted to work on our strong links, the bits of us that we know are performing well. Like, I'm really good at this thing, so I'm going to do more of that thing. Where there's probably more value in just looking across those aspects and like, yeah, oh man, I'm in great shape, but my sleep and mental health are a mess right now. You're probably going to get more value from working on your sleep and mental health than, trying to improve your marathon time or your deadlift PB.
It's like coming back to those fundamental things that your whole body needs, like strengthening that chain, as opposed to just going for a certain goal that you're focusing on one thing and then forget about your weakest links, essentially.
Yeah, absolutely.
When it comes to physical symptoms that someone could see on them now of metabolic issues, like their cells aren't working well, what are some things that someone might be able to see and notice within their body and their own symptoms? And also some things that might come back on blood tests, or what you would be looking for on a medical standpoint?
Yeah, absolutely. So I think it is worth us addressing the weight and BMI and measurement thing, what we call anthropometry, which is the measurement of the shape and size of the body and what that means. Those are, if treated with the right amount of respect or sometimes the right amount of disdain, those are actually useful as almost screening tools. So things like, and you'll find all sorts of charts around BMI, probably hip to waist ratios or waist to height ratios. Probably the combination of all of those are more useful than any one by themselves. But there are measures we can take in the body, but I would describe these as screening tests. They don't in themselves define disease. So people might like to do that in the privacy of their own home, or with a non-judgmental healthcare practitioner or someone they know, run through those things. But I do think it's very important then to be clear that they are a screening test. If that BMI is above, this somewhat arbitrary number that we decide on, if same with the waist hip ratio, same with the waist height ratio, then really I'd put it in the same category as if a mammogram was positive or a pap smear came back positive. It doesn't mean you have a life-ending serious disease that you must go and treat.
Mm-hmm.
It is just an invitation to seek more information. So if someone goes and there's a spot on the mammogram, someone notices a lump on their thyroid, and we go into the ultrasound, we don't just start removing bits of people. We don't just book operations or start medications or do those things. We go and gather more information and make sure that we find out if there is a disease there or if this is just a normal variant. We find out the stage of that disease. So we figure out how troublesome is that disease, what is the chance of it progressing, what is the chance of it causing harm, disability, death, etc. From there, and I think again this is done well, really well with a caring and non-judgmental professional that's out to help you, not give you advice. Look at, we tend to divide the effects of obesity into mechanical. So things like, am I sleeping well? The sleep apnea thing is my partner noticing I'm stopping breathing overnight. But also joints. Do joints hurt? Are joints not functioning as they should? Is getting up, getting down off the floor becoming a problem? Those day-to-day life things. And again, there's a really good set of resources out there from all over the place where you can just put yourself through simple movements and just make sure that that your body's doing the things it needs to do. We then talk about the metabolic, and that is where you really need the help of a practitioner that can order investigations. In my practice, we would very frequently look for signs of metabolic ill health in the liver. So there's a simple blood test and a calculation called the FIB4 that can give us an idea of the chance of someone having metabolic associated liver disease. There's what our pancreas is doing. And so there's insulin glucose ratios and a test called an HbA1c where we look at over the life of a red blood cell, how much extra glucose is it coming into contact with, and as a measure of, is my body doing a good job of keeping my glucose levels where they need to be for health? Then there's also the cholesterol issue. Again, is my body's doing a good job of handling the fats it needs to move around the body, or is it doing that in ways that might be harmful to me? And then also, depending on personal and family history, knowing, and particularly from the family, what might be in the future. What genetically might you be primed for? There may be other tests that we'd look at to get an idea of that. And all of this is around taking that screening test into an information gathering exercise and just getting a really good idea of, okay, what's the current state of play? Where are we at now? And what's the opportunities from there?
A quick pause before we continue. If you're listening to this episode, chances are you're trying to make sense of a symptom, whether that's weight, fatigue, PMS, brain fog, hair shedding, acne, or period pain. Maybe you've run the tests, being told everything looks normal while nothing actually feels normal. I want you to hear this clearly. Your symptoms are real, and your body is communicating, and you don't actually have to figure this out alone. After decades of trying to find answers for my patients and myself and studying across the various fields of healthcare, I created the Fundamentals Framework because the healthcare system hasn't had a space for women who feel stuck between symptoms and answers, and I wanted to fix that by giving you clarity and a way forward without being dismissed, overwhelmed, or disconnected from your body. Inside our clinic, you work one-on-one with a registered healthcare practitioner trained in this method, complete science-backed functional testing that looks beyond bloods, and build a personalized roadmap based on your body, not trends and not bias. Not to fix you, but to understand you. If you're ready to stop guessing and start listening differently to your body, you can book a free clarity call via the link in our show notes. Appointments open early 2026. All right, let's get back into the episode. If someone is like, okay, yes, I have metabolic disease, it's showing up on my bloods, on different screenings, When it comes to GLP-1s, the medications now that it's very popular, a lot of people are talking about it. How do they work? Do they work on metabolic health? Are they just for appearance? Tell us a little bit about them.
Yeah, so they can be all of those things. The GLP-1 agonists that we have at the moment are an artificial chemical that stimulates a certain receptor in the body that normally responds to the GLP-1 hormone. So one thing to say is that these aren't actually GLP-1 hormone; they're a synthetic molecule that interacts with that hormone's receptor.
Mm-hmm.
So it functions in much the same way in terms of the effects as your natural GLP-1 hormone, just that's greatly amplified. And GLP-1 receptors are all over the body. And therefore, these have a widespread range of effects through the body. Probably, obviously the most reason, famous reason, the aspect of them that's most famous at the moment, and the reason that's gathered huge interest is their ability to reduce weight. And when we look at how that happens, the first step is to actually go back and understand, well, how is weight maintained? Because I grew up, and even in medical school, with this very rudimentary idea of energy in, energy out. So you eat some and you exercise some, and what's left over becomes fat. And what was left out of that whole equation was actually, that's a very complicated, well-controlled process. And so we sort of have the idea that, if you and I stand, you stand at one end of a car and I stand at the other end of the car, then the harder I push versus you, the car will move in one direction or the other. And we completely forget that there's an engine and a driver and a steering wheel and a park brake in that car controlling whether or not me pushing or you pushing is going to have an effect. And so that is, and we are unwrapping bits and pieces of that picture at the moment. I'm fair to say there is still a lot we don't know about how the body controls weight. What we do understand so far is that the body likes to operate within a narrow set of parameters. It likes to keep our temperature in a certain range. It likes to keep our oxygen levels and the salt levels in our blood in a certain range. And it likes to keep our weight. And I would think of this less as weight and more as total body energy stored, because the tissue we're carrying around can be converted into energy in times of shortage. So the body likes to keep its energy stores in a narrow range. And so you'll often hear this idea of the weight set point. It's probably a little bit more complicated than that. I think dynamic set range is a better phrase to use. It's not quite as easy to say, but it explains it a little bit better, because we do operate within a range. There is acceptance of some tolerance, and that range will rise and fall throughout life. Some women will find their weight goes up and down with their menstrual cycles. Things like seasonal. Some people will find during the winter or summer, weight goes up and down. Times of stress, on holidays, all these sorts of things. And of course, there's all the input from the world around us changing. So as our environment changes, the body responds. So it's a very complicated range, but there is a range there. And then when we aim to reduce our weight, either deliberately or because of something like our cancer that's stopping us from eating, or we're in sub-Saharan Africa and we don't have enough food, it doesn't really matter. The body detects that decrease in calories and fights back against that. Furthermore, when that weight reduces, we can see a measurable hormonal and neurological response to that, designed to restore that weight. And so it's around 1% to 3% or more, the body really kicks in, and it will kick in and activate all of these weight gain processes and keep them going as long as it needs to bring us back to where it is comfortable in that range of weight that it wants to be at. And so we can often get ahead of that. We can often push through, but a lot of these mechanisms take some time to ramp up. So people often find they lose a bunch of weight, and even though they're sticking to the diet, some of that weight comes back on. And oftentimes, even if they stick perfectly to the diet, they may even end up back when they started, because that's what the body is kind of functioning to do, is to restore that weight. And the more we look at this, the more complex this gets. This is really a whole body regulation system. Part of that regulation system is in the brain, and it's back in the hindbrain, the lizard brain, the sort of, the background brain that we often talk about, in a place called the hypothalamus, deep down inside. And one of the sets of receptors for GLP-1 is in that hypothalamus. And when GLP-1 hits that hypothalamus, and particularly when these synthetic GLP-1 mimics hit that hypothalamus, it seems to lower that set range. Not to the same degree for everyone. And in some people, it doesn't actually work, because we're all a bit different and we all respond to different hormones. But for most people, it substantially lowers that set range. And so then the body goes chasing a new set range. So things that I think are important to understand there is, because we talk about these as weight loss drugs or as appetite suppressing drugs. And really, if you understand, no, it's actually more of a turn down the thermostat type drug. It's a lower the range type drug. So the loss of appetite and the weight loss are actually secondary to adjusting that set range. And the reason I think that's important to understand is, predictably, we'll get that point where the body enters its new set range and weight loss will stop. Whether we're happy with that degree of weight loss or not, it's going to stop, because that's where the body wants to be now. And again, appetite will often come back at that point, usually not to the same degree. Food noise may come back, usually not to the same degree. But that is the normal, predictable response to these. If we understand this, then it's also predictable that when we stop that medication and our set range comes back up again, our body is then going to drive us back up to where we started, and sometimes above. So I think you need to be empowered with this knowledge and this understanding to really make good decisions around these medications. And I think sometimes that's oversimplified. Oh, it's a weight loss drug. And so if you think of this as a weight loss drug, an appetite suppressing drug, and after a year you've been on this thing and your weight stopped falling and your appetites come back, well, why the hell would you stick on it? But if you understand what's going on behind the scenes, then you're more likely to make sort of good informed choices about how you use these medications.
That's so interesting. So that's got me thinking, well, what actually controls someone's set point, regardless of GLP-1s, regardless of that? Like, why would my set point be different to my best friend, to my mum, to my cousin, you? Like, what controls someone's set point?
Yeah. In short, the more I read on this, the more there is around this, the more things we find that affect set point. But in general, I'd put them into a few buckets. One is genetics. And it's not just the genes we carry from our parents, but the way those genes are turned on and turned off, another thing called epigenetics. The next is our development. And so that's affecting the epigenetics, but that's the things that happen to us while we're still inside our mothers, even the things that happen to our parents before we were conceived, the things that happen and during in the womb, and then the things that happen in the first 5 years of life, really before we're making conscious decisions about foods that we eat and diet and that kind of thing. So there's that development phase. Throughout life, then there are hormonal and aging and medical related issues. And so for women, puberty has a big impact, childbearing, breastfeeding, menopause, again, stress in our life, these hormonal things. Some people will develop thyroid conditions. Some people will go on medications that contribute. So that hormonal medical issue as well. And then the environment. And so we do have some control over aspects of our environment, but I'm talking about the wider macro environment, the food environment and the social environment that we live in, a lot of which we don't have control over, that is unique in human history. It is unique and spectacular in human history to be living in an environment where we have enough food pretty much all the time. And to have that from the time that we are conceived right through to fertility and beyond is unprecedented in human history. So we have a new environment we're living in. And then there is also the deliberate diet and lifestyle factors that we engage in. So if you look at all of those buckets, they're all pretty powerful buckets, but most of those buckets are things outside of our control. And so we do have some control over our diet and our lifestyle and the things that we allow into our microenvironment. But the vast majority of our set point is made up by genetics, development, aging, hormonal and medical related conditions, and the wider environment. And so kind of one of the five we get to really, really influence. And I think that's where a lot of the frustration comes from, is we are often led to believe, deliberately or otherwise, that we have a lot more control than we do over this set point and where our weight ends up. And often that comes then with blame and shame, right? If I'm in control and it's not happening, then it's all my fault. And this is a key source of distress for a lot of, men and women in this country. So an idea is it's my fault. And they have this experience of, oh my gosh, well, if I'm responsible and I need to do these things and they're not working, then it must all be my fault. I'm a failure, et cetera, et cetera. Whereas we could just step back and say, hey, and oftentimes when we step back and look at this more objectively, we actually find a lot of those people that are considered failures or are considering themselves failures are actually doing very well. I'll have women walk in maintaining 10+% body weight loss over 5, 10, 15 years. Scientifically, they are absolute super achievers, but because they haven't hit this fictional idea of the healthy body size shape for women, they feel like a failure. And it's horrible. It's horrible to see. It's horrible to see people take this to the extreme where you can see that their perception, their feelings around self-worth and their value to society has been impacted by this myth of it's all on you. You have complete power and responsibility. So if you don't end up a certain size, you're a failure. It's really hard to do to women, and particularly women, like men as well, but particularly women in this space.
Yeah, absolutely. So if someone is listening to this and they're like, well, I can't control what family I was born into, my genes. I can't control what I was fed, what my parents were eating when I was conceived. What would you say to them? Like, are you saying like, well, GLP-1s are a great resource for you? Or are there people, because I do know some people, like obviously, as you said, like those are the main levers that you can't really impact, and you can impact the lifestyle and diet and things, the things that you do have control over. What would you say to those people that are like, well, everyone in my family is overweight, so it must just be genetic and I can't do anything about it? Like if someone's feeling like that, what would you recommend to them?
The first thing is, one, it's not your fault, but you do have agency. So it's not all your fault. It's not all your responsibility. You're not to blame and shame, but there are really good, impactful things that we can do. There are things that we can do without medications and without surgery. And a lot of women and a lot of men are already doing them, but there may be things you can do. There are now a suite of medications available and many more coming that will not remove those influences. They won't change your genetics. They won't take away your life experience and your development. But what they can do is manipulate that system around weight maintenance and about all that complex metabolic disease stuff we talked about to have real impact that will build on the things that you're already doing without medications and surgery. And then there's metabolic surgery, which is, sort of the next level of impact, if you like. And it's not that any of these things are better or worse. It's just that they're different. Metabolic surgery has a greater impact that lasts longer. Right? GLP-1s have a bit less impact. Yes, their effect is temporary, but you can take them safely lifelong. And then there are unique and important health promoting aspects to exercise and diet that have nothing to do with your weight. These are still magic in your life, they're just not good obesity treatments. It doesn't take their value away. They're just different. They're still, and so really it's a matter of, well, let's sit down, figure out where we're at, set some meaningful, achievable goals that matter in your life, and go, and we have the tools, and go out and achieve them. There is agency and there is hope here. We do. We are living in a time where I couldn't have said this 5-10 years ago. Really there was such a big gap. Now we have this full range. And the last thing to say is about this, to be very clear, that it's not a matter of one or the other. It's just about what's the right thing in your life at this time, and having and understanding this is a chronic, lifelong condition, and it is appropriate to pivot and flex and change approach as life goes on. It's an exciting area of medicine, and partnering with a healthcare professional that understands the full range of options now, the ability to assess not just this obesity impact, but also start to unpack some of those things, some of those unlearnings around self-worth, deal with the nutritional side of things as well. And all over this country, we are seeing more and more people engaged in that really comprehensive, holistic approach to this, using all tools available to them, freely and without judgment and stigma. And it's great to be a part of that. I feel like around the country, like I find my tribe, I meet all these people that are just like, no, we're going to use all the stuff for whoever needs whatever they need, and we're just going to go and do this. And it, in some places, it's starting to feel more like basic good medicine. The type of medicine we practice in other areas like inflammatory diseases or cancer care, where instead of sitting down and saying, is this better than this, or you should just try harder, we actually just examine, assess, make a plan, and then use all the tools we need to use to ensure that we get an optimal outcome for that patient, and then adjust our plans as we go through life.
Okay, I want to hit pause on this conversation just for a moment and bring this home to you and your body. If you are listening and thinking, okay, cool, Anthea, but how would I even know if my metabolism is happy or not? Because remember, our body is always giving us all of these signs and symptoms to tell us what's happening underneath the surface. So if there's metabolic dysfunctioning happening underneath the surface, there's some signs and symptoms your body could be giving you. Number one, skin tags. So if you're noticing skin tags around your neck, armpits, under the breast, this can be a warning sign of underlying insulin resistance. You also might notice that you have darker velvety-like skin in the creases of your body. You also might notice that you have tight, puffy or discolored lower limbs, so around your ankles. You might notice that hair has stopped growing. So you're losing the hair on your toes and your lower ankles as well. You might also notice that you feel puffy or swollen in general, and that your energy and mood swings. So you have those hangry crashes, the brain fog after meals, needing sugar and caffeine to get you through the afternoon. Those are some warning signs from your body that, hey, you need to support that metabolism. And if we think about it from a medical standpoint, some things that you can talk with your doctor about and what your doctor will be testing for are things like your blood pressure. Is that creeping up? What about your fasting glucose, fasting insulin, and your HbA1c? These tell us a lot about your blood sugars, which is a main component of your metabolic health. We also can look at liver enzymes, your lipid panel, and then also taking into consideration your family history as well. Remember, your body is always talking to you. All of these symptoms are not random. They're a way that your body is trying to help you say, hey, we don't have what we need. You really need to start supporting this part of your body. Now, let's get back into the episode and understand more about metabolic health and weight and what you can do about it from a medical standpoint with Dr. Alex Craven. Context is everything. You can't just go, it's calories in, calories out. You're not trying hard enough, was the old model. And now it's, well, what tool is going to be the best thing for you right now? It could be a GLP-1, it could be gastric sleeve, it could be more exercise, changing your diet, it could be looking at shame, looking at worth stories, all of those things. And I think that's incredible, the work that you're doing to tie all of that together.
I think one thing I think I say, Anthea, too, is that it's important that people like you and I guess people like me are talking about these things openly and encouraging their use, because this is a funny area of medicine where people feel like because they don't need that treatment, they should block other people from having it. You know, I'm never going to, like, realistically, I'm never going to need breast cancer treatment, but breast cancer treatment is really important. And I will absolutely support excellent, high quality, wraparound supportive care and all of the modalities a woman needs for breast cancer treatment, even though I'll never need it. And I would look like a real prick if I was to say, well, no, I don't need breast cancer treatment. We should not be doing that.
Yeah. That makes so much sense when you put it that way.
You know what I mean? Like, when we feel like we say, okay, well, I am also realistically, unless there's really something coming for me I cannot predict, if I look at my family tree and all the things that have happened to me and all of the terrible lifestyle-related eating behaviors and lack of exercise that have gone into my surgical training, if I looked at that and see where I am now, I'm not going to need metabolic bariatric surgery. I am not going to need a GLP-1 agonist. Realistically, not going to happen. But I still stand up and say the people that do need it have a right to access it when that is the best evidence-based option for them.
Yeah, absolutely. I think it's always the context and the person. When you're saying that, it comes to mind, I do have a couple of people that I know that don't have metabolic symptoms or disease, and they also are not what you would classify as someone who is overweight. Like, their BMI is very reasonable. But they want to take GLP-1s and they're accessing it through ways that they shouldn't be, essentially. What are the risks of taking it when you actually don't need it?
Yeah. So I think what's important there is one, we do want to be a little bit careful, because there's a lot of sort of criticism about celebrities and people that we put in a barrel of, they don't need this, they're already skinny. And I think the important thing you mentioned there is just making the judgment that someone doesn't need these medications based on their body size is fraught, because when you scratch beneath the surface, we've seen the conditions that occur that can really be harmful can be completely out of whack with rise in BMI and body weight. You know, metabolic liver disease, about 10% happens in people that don't meet our criteria for overweight, right? So, and metabolic liver disease matters, not just for liver health, but also as a risk factor for cardiometabolic disease and all those sorts of things. And there's lots of other examples where, you know, we shouldn't be prescribing these outside the guidelines, but as we go on with more and more evidence, we are going to see more and more people that don't fit our idea of obesity because of their body size are going to need this. So that's the first thing I'd say about that is, you know, we'll be careful, because you may not know what's really going on under the surface on that person's blood tests, on their imaging or whatever else. And that may actually be a really sensible option for them. Having said that, there is also the element of, let's face it, the popularity of these is driven in great part by their perceived cosmetic benefit. You know, they make people smaller in a world where a lot of women particularly are pressured to be smaller. And so they do have a role there. And I guess my personal philosophy around this is it's probably time for us as a society, rather than adding another layer of blame. And so now we're going to blame, we're going to blame the big people for something that's not going to, and now we're going to blame skinny people, and then we'll blame. It's probably, to me, time to look at that again as a symptom of something else that's going on here that we've known about for a long time. That we put extraordinary amounts of pressure on people, particularly young women, to look a certain way. And it is, again, multifactorial. It is in the way we speak in individual conversations, right through to mass media, social media, and what we praise and glorify from on Instagram and TikTok and all these sorts of things. This, this again, it's a symptom of a bigger societal issue around what we say about people's bodies that's driving this. And I'm more interested in tackling that than the individual that's choosing to do that. Having said that, we do need to be careful that people are safe. When people lose weight, they will always lose both lean mass and fat mass. And in most cases, what we're trying to do is reduce adipose tissue, or what we're actually trying to do, really, what I'm trying to do from a medical point of view, is improve that metabolic biological health. And the fat tissue going away is a happy side effect of better metabolic health. So that's not really my aim. But what I'm getting to is that when weight comes down, some of that weight will always be lean tissue, the tissue that we want, bone, muscle, functional stuff. And that tends to be a bit of a threshold thing where it's kind of okay to lose a bit, okay to lose a bit, okay to lose a bit, until you lose so much that you're really in trouble. And so, one, we want to make sure that if this is happening, that people do have resilience, if you like, to have enough lean mass and enough lean tissue and enough strength that's not likely to get them in trouble. And two, we want to do all the things we can do to maintain that lean mass while we do these things, whether it's metabolic surgery, whether it's GLP-1s, whether, there isn't clear metabolic benefit or health promotion benefit aside, anyone on these medications, there are things we know we can do across the whole population, old people, young people, men, women, whatever, to preserve lean mass and function. And there are common nutritional deficiencies in this country that only get worse when you eat less food. And there are, eating disorders are very common. And so the use of this may actually be a manifestation of an eating disorder, and eating disorders are very treatable conditions. And so I think when we're seeing that, as a medical practitioner, I see my role, one, as to speak out against the pressure that's making someone use this medication when really there's no solid health benefit we could see. Two is to ensure, okay, are we missing something from a nutrition point of view? Are we maximizing lean muscle retention? And are we missing something from a psychological or mental health perspective that is an opportunity to improve someone's health? Doing that to take the medications away from them. What we're doing that for is, well, okay, instead of taking one step forward in your physical health and two steps backwards in your mental health or nutritional health, what we'd really rather see is we take one step forward in each of those. Metabolic health gets better, and nutritional health gets better, and mental health gets better. And we can do that. But I think in a lot of circumstances, it's hard to do that or know when that's necessary if you're just ordering something online after a 2-minute phone conversation. It is a worry that we're missing a lot of opportunity there.
Is there any red flags or big contraindications for people that shouldn't be taking GLP-1s?
The only real absolute no-go red flag at the moment would be a condition called medullary thyroid cancer. It's a rare form of thyroid cancer, and we believe the GLP-1 receptor is involved in the development of that cancer. So people with a personal family, anyone in the family that's had medullary thyroid cancer, or if the person's had it, we just absolute no-go, don't even. There are a few times we want to be really careful. Pregnancy and fertility is one. They're not recommended during pregnancy. Currently, we don't know they're safe. And we've got to be particularly careful because treating those underlying metabolic issues can actually improve fertility for a lot of women. And so we have a saying of super fertile, where women suddenly find themselves more fertile than ever, and they might have been getting away with things that they won't get away with anymore, particularly if their fertility is based on obesity or polycystic ovarian syndrome type conditions. fertility may come back in a hurry, and so we've got to be careful. The other is where we are worried about, we're predictably going to see some weight loss. We're predictably going to see people eat less food. So in that setting, we want to be screening and making sure, are there existing micronutrient deficiencies or deficiencies in the diet in terms of protein and fiber intake and the like, or eating disorders? Are there already issues around relationship to food? And so we really want to make sure that people have a good relationship with food as they go forward on these medications, and they're nutritionally safe. But overall, it's got to be very clear that these are very safe medications. GLP-1 receptor agonists in some form have been around for decades now, and we really haven't seen any concerning signs. Some of the dual agonists are introducing new receptors we haven't targeted before. So the Manjaro, for instance, and there's more coming down the line. Perhaps we haven't looked, but so far we haven't seen any real worrying safety side. One of the things, though, that I will say is the most common issue, or not the most common, one of the common issues we're seeing at the moment, though, is people for whom this is not enough. And so they're staying on the medications. They're often staying on low dose, Ozempic, for instance, which is a low dose version of semaglutide, sometimes for cost, sometimes because of misunderstanding, and it's not meeting their treatment goals. So that is one thing that we want to keep alert on. Again, not such a problem if there's not anything life-threatening coming down the line, and if that's not affecting their movement and their health and their quality of life. But if people are negatively affected by these processes of obesity, we really want to be stepping up and treating that. Overall, everyone can expect at some point on these medications to get a few weeks, and it may not be at the first dose, but a few weeks of gastric upset, slow down, feeling nausea, not wanting to eat, turned off by food, all those sorts of things. Most of that settles. And if you have an experienced practitioner that's used to using these medications, you can almost always get through that. And if you're having issues with tolerability, probably that's a good time to go and find someone that uses these medications a lot. The other thing is we want to be a little bit careful about making sure people know the expected duration of therapy. We have a really frank conversation about, given their circumstances, are they one of those few people that are likely to be able to get away with short-term therapy, or are they one of the vast majority that are going to need to be on this lifelong, and what does that mean for them, and how are we going to manage that as well? But really, at the end of the day, these are safe medications and effective, and the quality of the results that people get really depends more on the care team and the skill and expertise of the team that they're engaged when they're using them, more than the medication itself. The medications work as well as they work. It's just whether or not the rest of the aspects that we need for success are being offered is really the key to ensuring success and tolerability of the medications for most people.
Dr. Alex, thank you so much for joining us and sharing your very vast, very knowledgeable wisdom. I just wanted to ask you, on a final note, is there anything that you would like to say to a woman that is listening to this that has been struggling with her weight, her metabolic health for a long period of time? What would you want to say to that woman?
This is not your fault, and you have a right to evidence-based treatment. And I'm sorry that at the moment, the medical and healthcare industry is not doing a good job of providing that. It's not okay, and it's something that we need to work better on. You have a right to stigma-free, judgment-free discussions about your health, whatever that relates to. You have a right to access a quality team that can help you with not just your metabolic health, but also your nutritional and psychological health. Mm. And you have a right to access medications and metabolic surgery. They're the big four. You have a right to all four of those things because they're all evidence-based. And we have a charter of healthcare rights in this country that says that's what you should be getting. And if you're not getting that, go and find someone that can provide it to you, because there is a tribe of us trying very hard to make this available. The last thing I'd say is, if anyone out there, whether they're affected by obesity or not, please talk to people that make decisions about this. Talk to hospitals. If you have a hospital near you that's not providing metabolic bariatric surgery, what the heck? Go and talk to your CEO. It's time for them to do that. If you have, an ability to engage with healthcare administrators, departments of health, politicians, or just talk about this on social media, make it clear that, it's not okay that we stop providing this type of treatment just because it hasn't been popular in the past. And also that there's hope. There's really good treatments available. There's great combinations of treatment. There is a growing expertise in this area that's spreading through the nation. And we want to help. We love doing this type of medicine. This is really a fulfilling, enjoyable medicine. I get to change people's lives, and it's great. Don't feel that you're burdening your GP with this. If they get this, they will look forward to the opportunity to engage on metabolic health. The right care team for you would just be like, yeah, let's do this. It is great to see people's lives radically changed by this. It's the only thing I do in all of medicine and surgery that makes people live longer and improves their quality of life. Normally I'm compromising one for the other. This does both. It's great. We want to do it. We want to help you. We want to be involved.
Amazing. Thank you so much for joining us, Alex. It's been an absolute pleasure.
Pleasure. Thanks for having me.
Thanks for listening to our Weight and Metabolism series. It's designed to help you understand that your weight is a message from your body, not a character flaw. If something in this series resonated with you, let us know in the comments below. Check out the show notes for important follow-up information and links, and make sure you're subscribed so you never miss what's coming next. Please remember, this episode is for educational purposes only. Always consult a qualified health practitioner before making any medical decisions. Every body is different, and so is every healing journey.